All right. Well, it's 8 a.m. Let's get started. Good morning, everyone, on this brisk fall day. And delighted to have all of you at our medical grand rounds. Just a reminder, one, to fill the evaluation out at the end. And then second, just a reminder that we're having a town hall next Wednesday. So I hope to see you all, at least virtually, there. So today, to introduce our Grand Round speaker, Dr. Karaman, is Dr. Vince Crines, who is the Division Chief of Endocrinology. So Vince?
All right, good morning, everyone. I am thrilled to be able to introduce today's Grand Round speaker, Dr. Rowan Karaman. Rowan is a graduate of The Ohio State University. She got her bachelor's and her MD degrees there. Then she did her internal medicine residency at the University of Chicago, and did a few years as a hospitalist before joining us as an endocrine fellow. And as a fellow, she has worked with Molly Carr in the Advanced Women's Health Fellowship and is in the Master's in Clinical Investigation program. I believe she's likely to get her degree this June or May. And the project she's going to talk to you about today is a great illustration of bench to bedside research. So her mentor, one of her mentors, she has several, Dudley Lamming, was interested in this idea of protein restriction. So it's been known for quite a while that if individuals, everything from mice to people, restrict the amount of protein they eat, that they lose weight and they have improved metabolic health. So Dudley wanted to figure out, well, what's the basis of this? Which amino acids are relevant? And so he discovered that branched chain amino acids, leucine, isoleucine, and valine, if mice restricted their consumption of these, they actually could eat more and lost weight, and they had improved metabolic health, both in healthy mice and in mice that were fattened up on a Western diet. So Rowan is naturally asked, well, will this work in people? And so let's find out. So we're excited to hear what you have to say, Rowan.
Thank you, Dr. Crines. Perfect. I have no relevant financial disclosures. And like Dr. Crines said, today I'm going to be talking about how branched chain amino acids work in the world of diabetes. As far as our learning objectives go today, I do want a little refresher for you on how to diagnose both prediabetes and diabetes on glucose and A1C criteria. And I want you to be able to leave here with just a kind of an overview grasp of how insulin resistance works. A 42-year-old patient of yours walks in, no significant medical history, has a hemoglobin A1C of 5.9%, which you may or may not remember is actually elevated, BMI in the obese range, and an elevated blood pressure. Your patient tells you, you know what, I work out every day of the week. I bike, I walk, I kind of watch what I eat. I try to be careful. What's going on with my body and what can I do about it? Now, maybe the initial response that you'd have for this patient as well, perhaps you're not cutting your carbs enough. Today, I'm going to present data for you that may be a little different than what we're used to. So what if it's not just carbs that we have to worry about? What if it's not just saturated fat that we have to worry about? What if protein plays a bigger role than what we had previously thought? I'll talk about the pathophysiology of insulin resistance, how protein and insulin resistance are linked, then in particular the branched chain amino acids, their role in insulin resistance, and our clinical trial, the SOAR study. As we all know, diabetes is quite prevalent in the world and is growing, particularly in the lower income countries. Over 400 million people across the world have diabetes. In the United States, 10% of us have diabetes. A whopping quarter of the population has prediabetes, and 90% of the people with prediabetes don't know that they have it. Obviously, with that many people who have this pathophysiology, it incurs a great cost, not just in direct medical costs, but also in decreased productivity. Here's the refresher on how we diagnose diabetes. There are several methods to do it. One of the most commonly used ones in the primary care setting is fasting plasma glucose on the BMP. So normal fasting plasma glucose is under 100. Prediabetes range is between 100 and 125. And this is where it often gets missed, because you look at the BMP and it's like 101, 102, that's fine. Actually, that's in prediabetes. And if it's the fasting glucose that's elevated, that gives us impaired fasting glucose. The diabetes range is over 126 for the fasting glucose range. Less commonly used for screenings, although we do use it to screen for gestational diabetes often, is the oral glucose tolerance test, where the patient will drink 75 grams of dextrose in a soda, and we measure their glucose 2 hours after that. Prediabetes range is between 140 to 199. Diabetes range is over 200, and normal is under 140. A1C, quite commonly used. Prediabetes range between 5.7 to 6.4. Again, sometimes gets missed in that 5.7, 5.8 range. Diabetes is over 6.5. In the if you're doing an oral glucose tolerance test and the patient has a blood glucose from 140 to 199, that's impaired glucose tolerance, because you're giving them a glucose load and their blood sugar is high afterward, not tolerant as they would have been in a normal range. So both impaired fasting glucose and impaired glucose tolerance are part of prediabetes. A patient can have both or one or the other. Let's talk about insulin physiology. So insulin starts off as proinsulin, which is a chain of 86 amino acids. They're cleaved in a couple of different places, which leaves this insulin chain. It's an A chain here, a B chain here, and the connecting peptide, or C peptide. So it's a chain of amino acids, 2 chains actually in insulin's case. Insulin has a short half-life, 3 to 5 minutes. It's degraded in the liver and the kidney. And we all have a baseline insulin production, even in the fasting state when we're not eating. That's basal insulin. That's why we give basal insulin to patients who require insulin. And then we spike up our insulin when we need to in case of a carbohydrate load. This is a depiction of insulin secretion from the beta cells that produce insulin in the pancreas. So we start off here in the upper left with glucose being transported into the beta cell, and they are phosphorylated to glucose 6-phosphate by glucokinase. It enters the glycolysis cycle. This creates pyruvate, which goes into the mitochondria, is converted into acetyl-CoA, and then feeds into the TCA cycle, which produces energy, which is ATP. When ATP levels rise, this ATP sensitive potassium channel closes. Blocking the potassium current depolarizes the cell, which allows these voltage gated calcium channels to open. Calcium influxes into the cell, which drives the fusion of insulin granules with the cell surface membrane and exocytosis of insulin. Insulin's a hormone. Hormones work via receptors. So insulin binds to the insulin receptor, which is composed of alpha and beta subunits, as well as tyrosine kinase, which initiates the signal transduction cascade, which you see down here. what does insulin do? Well, we know insulin has a massive role in the liver. It's anabolic. It promotes glycogen synthesis. So we make glycogen. We also make fats, triglyceride and VLDL. So it promotes glycogen and lipogenesis. At the same time, it's inhibiting catabolism, right? Because it's anabolic. We also want to inhibit catabolism. So it's making glycogen and inhibiting the breakdown of that glycogen. It's inhibiting gluconeogenesis, or creating glucose, and it's inhibiting the conversion of fatty acids and amino acids to, because we're promoting lipogenesis. In the muscle, it leads to protein synthesis by increasing amino acid transport. And it also makes glycogen by increasing glucose transport in the muscle. And the fat, it promotes storage of triglycerides by inducing lipogenesis and inhibiting lipolysis. And it has effects in decreasing appetite and increasing energy expenditure. So that's when things are all well and good. What about when it's not in such balance? Here's the pathophysiology. And I really, really want to emphasize here that this talk is about prediabetes and type 2 diabetes, which is our classic insulin resistance, relative insulin deficiency states. This talk is not about autoimmune types of diabetes like type 1 diabetes and others like it. Those are characterized by pure insulin deficiency. That is, the beta cells are not making insulin. This is a different pathophysiology. So two components in prediabetes and diabetes: insulin resistance, the decreased ability of insulin to stimulate downstream signaling in target tissue, and also relative insulin deficiency. So this does not mean that the beta cells aren't making insulin. In fact, a lot of the times they're making more insulin than it would have normally. It's just that for the amount of glucose that's in the plasma, it's not enough insulin to bring it into the liver and into the muscle. Now, again, I want to emphasize prediabetes and type 2 diabetes are on a continuum. The pathophysiology is really the same between the two. So we've made the cutoffs on diagnosis of prediabetes and type 2 diabetes really based on when complications happen, what glucose complications happen in the future. And that creates sort of a false binary where it's really a continuum. The pathophysiology is the same. So we talked about this before. In a normal state, we're promoting glycogen synthesis, lipogenesis, inhibiting glycogen breakdown. But now when we're not in homeostasis, we have increased gluconeogenesis and impairment of fatty acid oxidation. Instead of glycogen synthesis and storing triglycerides, we have reduced glucose uptake. We have increased lipolysis. And let's talk about the fat tissue for a little bit more. So fat tissue is made out of fat cells, adipocytes, which are able to hold fat, more and more fat. Sometimes in cases of overnutrition, they can no longer hold as much as they used to, and that fat storage is shunted to elsewhere in the body. So adipocytes, fat cells, are not inert. Actually, for many, they're considered an endocrine organ. They produce adipokines, which are a group of hormones and cytokines. They all function differently. Some of these are adiponectin, leptin, resistin. They make chemokines, cytokines, lots of other things. They all have different roles. They all function differently. For instance, TNF-alpha, IL-6 inhibit insulin signaling. Adiponectin enhances insulin signaling. But when we're in a state of overnutrition or sedentary lifestyle, these can come off balance and lead to insulin resistance. Let's talk about that insulin resistance for a little bit. Now, there's a lot going on in this slide, but I really wanted to dig a little bit deeper into why insulin resistance may occur. I do want to forewarn you, this is not the absolute truth about why insulin resistance happens. These are proposed mechanisms, but there will be researchers who would disagree and say there are other mechanisms that are equally as important, perhaps even more important. This is the type of thing that people can argue about for hours at conferences. But really what I wanted you to get out of this today is what are the components, how intricate it is, and just to offer you a little bit more information that's more than, oh, the glucose is high and that makes the cells less sensitive to insulin. So let's talk about that here. So we have overnutrition and sedentary lifestyle. That increases the fatty acid supply. Fatty acids, long-chain acyl-CoAs are fatty acids, so it increases long-chain acyl-CoAs. These long-chain acyl-CoAs go into the endoplasmic reticulum, where they are converted into other lipid species like triglycerides, diacylglycerols, ceramides. And this anabolic burden on the endoplasmic reticulum actually causes negative effects, like protein misfolding in the endoplasmic reticulum. These misfolded proteins then prompt stress-induced kinases, which have a negative effect on downstream insulin signaling. Additionally, an increase in insulin itself from insulin resistance increases malonyl-CoA. Malonyl-CoA has a negative effect on beta oxidation, which creates energy, right? So beta oxidation in the TCA cycle and ATP production. So that's less energy production in the mitochondrion. And outside of its effect on malonyl-CoA, it has that effect on its own by inhibiting beta oxidation. So that's the insulin aspect of it. Additionally, the inflammatory stressors, remember we talked about cytokines being created in the adipocytes, these also themselves prompt those stress-induced kinases, which impacts the downstream signaling at the insulin receptor. So this is in the liver, remember. So insulin would come here, try to bind to the insulin receptor, it binds, but something happens in the downstream signaling. And it's really the downstream signaling that drives the problem with insulin resistance, not binding to the receptor in and of itself. So that's everything. Increased insulin from insulin resistance, energy stress, increased fatty acids from overnutrition, and inflammatory stressors leading to impaired downstream signaling at the insulin receptor. This is in the skeletal muscle, looks very similar. The mechanisms here aren't as well delineated as they are in the liver, but it is still some theories out there about it. Again, same thing, energy stress increases the fatty acid supply, long chain acyl-CoAs. These go into the mitochondrion here in the skeletal muscle, and they do become beta oxidized, go into the TCA cycle, make ATP. However, there's overload in the mitochondria, and there's no simultaneous increase in TCA cycle flux. That increases reactive oxygen species, also prompts these stress-induced kinases, which negatively impacts downstream signaling at the insulin receptor. Now, in skeletal muscle, when we increase our energy demand with exercise, this actually does some reprogramming, which can bring that TCA cycle flux back into balance. So this is why exercise is pushed so heavily in patients with prediabetes, type 2 diabetes, and this is why it helps. So we have insulin resistance, we have inflammation, we have visceral adiposity. They all feed into each other bidirectionally and all contribute to insulin resistance. We know that the type 2 diabetes spectrum is impacted by both genetics and environmental factors. And although patients often have obesity. They don't actually always have obesity, and it really depends on the ethnic background of the patient as well. But even when patients don't have BMI that's in the obese range, they tend to have predominantly abdominal fat, high waist to hip ratio, and that could mean an increase in visceral fat. And we know that visceral adiposity correlates with insulin resistance. Now, this is a group of 52 men and women. They did CTs to quantify their visceral fat. And they found that with more visceral fat down here on the x-axis, their insulin sensitivity on the y-axis decreased. They did not find that this correlated with either subcutaneous or total fat. It was really with visceral adiposity, which is why it's so important in insulin resistance. Metabolic syndrome, you'll recall this as being multiple risk factors for both diabetes and cardiovascular disease, multiple components, high waist circumference. The International Diabetes Federation gives some very nice ethnicity-specific cutoffs for this. High triglycerides are on treatment for triglycerides, low HDL are on treatment, high blood pressure, and high glucose. All of these increase our risk for both diabetes and cardiovascular disease. We can measure insulin resistance by using fasting glucose and fasting insulin. This isn't a perfect test, but it's used routinely in the research setting. And it's called the homeostasis model of insulin resistance. And with increased HOMA-IR means we have increased insulin resistance. We talked about the insulin resistance aspect of it, and hopefully you have a grasp of why insulin resistance happens and why we push for diet and exercise so hard as treatments for the type 2 diabetes spectrum. There's also the beta cell aspect of it too. So turns out most people with insulin resistance don't actually have diabetes, and you'll see why in the next slide. Beta cells can actually increase both their mass number and the amount of insulin that they're secreting. So in this graphic, we have the insulin resistance here in the red, the glucose level in the blue, and the insulin production in the yellow. And then in normal state, things are in balance. The glucose levels are normal. But as we have overnutrition or a sedentary lifestyle, the insulin resistance rises. As the insulin resistance is rising, the beta cells start working harder. They start increasing in number, they start secreting more insulin, and for a while, they're actually able to maintain euglycemia. After a while, though, as the insulin resistance goes higher, they can't do it anymore. They start to malfunction. And when that starts to happen, our glucose levels start to rise. When the beta cells really start to be dysfunctional, even if the insulin resistance isn't rising at the same time, the glucose level starts to rise. And this is the continuum of the diabetes spectrum. So here are people with insulin resistance who have totally normal blood glucose, and potentially if you checked their C-peptides, they would be high with a normal glucose. These are those patients. These are the pre-diabetes patients, and here with more beta cell dysfunction is the type 2 diabetes patients. The natural course of type 2 diabetes is that beta cells will become more dysfunctional over time. Of course, this isn't the case for every patient. We do see patients who manage to control it with their diet indefinitely, but this applies to the majority of our patients. Back to our patient. So the diagnosis here, we said A1C of 5.9% puts the patient squarely in the prediabetes range. Do they have prediabetes? Maybe they have metabolic syndrome, right? Their BMI is elevated. Maybe they have an increased waist circumference. Their blood pressure is elevated as well. So you would still need a lipid panel, you need a waist circumference, but they potentially have metabolic syndrome. And now you can explain to the very curious patient who may appear in your clinic why that increases their risk for both type 2 diabetes and cardiovascular disease. All right, so your patient says, you know what, I know sort of everything about food. I track stuff in apps. It's fine. I'm not consistent with it, but I know how to do it. I'm not great at maintaining my weight. But what else have you got for me? Anything new? I know about all the programs. Got anything in the pipeline for me? When we counsel patients with prediabetes, type 2 diabetes, we have very strong evidence that weight loss of even 7% will reduce progression to type 2 diabetes. If they have type 2 diabetes, weight loss can also help, particularly when they're in the early stages of beta cell dysfunction, can help with multiple metabolic parameters. These patients are counseled by registered dietitians who will go through everything that they eat, try to work with them to manage both expectations and help them figure out how to meal plan better. But as we know, kind of the cornerstone of diabetes management thus far has been carbohydrate restriction, right? Look at your carbs, count them, cut back a little bit more, decrease your saturated fat, and also increase your physical activity. But what about protein? So the recommended daily intake for us in the United States is 0.8 grams per kilogram of body weight per day. This is actually much debated. The studies that came up with the 0.8 were physiologic studies that looked at people who weren't doing any activity. They did not have comorbidities, and this was the minimum amount to prevent protein breakdown in the body. So in general, this is considered to be quite modest. Most of us in the United States eat between 1 and 1.5 grams per kilogram of body weight per day. Most of us do actually get enough protein in this country. The American Diabetes Association does not give us any guidelines for protein intake, either for blood glucose management or to decrease the risk of cardiovascular disease. We've known for a while that protein and diabetes are somewhat related. This is NHANES data, and it is also National Death Index data, meaning that they looked at what was written down on their death certificates of these patients. They looked at 83,000 person years over 18 years. So that is problematic, right? Because most of our patients from diabetes don't necessarily have diabetes written down on their death certificates. It's often stroke, myocardial infarction, or what have you. But that being said, let's go with it. They did find that diabetes mortality, written down on the death certificate, increases in those with higher protein intake. In a prospective European study of 39,000 people with a 10-year follow-up, they found that diabetes rates increased in those with a higher intake of animal protein. They did not see the same effect for vegetable protein. And in mice, like Dr. Krein said, we know from Dudley lambing studies that a low protein diet improves glucose tolerance in mice. So this is mice that were placed on a low protein diet in the red here. The black is regular amount of protein, 21% protein diet. And this is an oral glucose tolerance test. So the mice on the low protein diet had lower glucose, which is better glucose tolerance. And these mice were eating equivalent calories, equivalent fat. The mice on the low protein diets ate more, but gained less weight. They had almost no fat mass gain. They had increased energy expenditure at night as well. This is the measure of insulin resistance, the HOMA-IR. And as you can see, the low protein diet had less insulin resistance. What about in humans? This was a low protein randomized clinical trial in men with a BMI in the obese range. They happen to also have localized prostate cancer. There's some data on lower protein diets in patients with malignancies. So the protein restricted group had 7 to 9% of their calories from protein. The control group had a normal amount of protein, 17% of calories from protein. And they were on this diet for about 43 days. The protein restricted group lost weight, 2.6 kilograms in those 43 days. Half of that weight was from fat mass. And they also had significantly lower blood glucose than those in the control group. So that's on a low protein diet in humans. Dudley Lamming has done quite a number of studies in the specific types of amino acids that we can remove and maybe see the same effect as removing protein in its entirety. So this one was on reducing the branched chain amino acids. There are 3 of them. This is in mice. The control group of mice had a control diet for 12 weeks. The intervention group of mice was placed on a Western diet or a high-fat, high-sugar diet. After 12 weeks, the high-fat, high-sugar diet were split into 4 groups. Those on a Western diet with a normal amount of amino acids, Western diet with the high amount of branched chain amino acids, Western diet with low amount of branched chain amino acids, and Western diet with low amino acids. Control group stayed on the control diet. We found here that reducing branched chain amino acids specifically promoted weight loss and reduced adiposity. As you'll see, this is the control group here and the white squares. This is weight here on the y-axis. The low branched chain amino acid group in the blue and the low total amino acid group in the orange were both lower than the control in weight after the diet switch. Their fat mass was equivalently low, also in the low total amino acid and low branched chain amino acid group. Additionally, their blood glucose was also lower in both of those groups. So reducing all the branched chain amino acids improves glucose tolerance and weight in mice on a low branched chain amino acid diet. The branched chain amino acids are valine, leucine, and isoleucine. These are essential amino acids, meaning they're not synthesized by us mammals. They're present in plants and fungi. They account for about 35% of amino acids and 2 to 5% of our energy sources. Not a lot of our energy sources, but we do have very efficient dietary uptake of it. And in homeostasis, there's a perfect balance between the intake and loss of the branched chain amino acids. Branched chain amino acids appear in our circulation when we eat them. So they go into this circulation pool. And when we need them to be incorporated into protein, like in exercise recovery, they're incorporated into protein. They can be broken down from protein in cases of acute exercise injury, tissue degradation. They go back into the circulation pool. And if they're not used in the circulation pool, they're oxidized for energy. So as opposed to carbs, which can be stored as glycogen in the liver or turned into fat, and as opposed to fat, which is stored as fat, there's no actual store of amino acids in the body beyond the protein that's in the muscle. So if you stop eating protein, you will start breaking down that muscle in order to get amino acids to survive. And if there's excess protein, it's broken down, it's oxidized, the nitrogen is excreted, and the carbons are turned into glucose or fat or used for energy then and there. This is how we get that energy. So leucine, isoleucine, and valine, they're worked on by a number of enzymes, and eventually they end up either as acetyl-CoA or succinyl-CoA in the TCA cycle. Maple syrup urine disease is where the function of this enzyme does not occur well. It occurs in about 1 in every 200,000 births. And when these branched chain amino acids accumulate, they start competing with other amino acids for transport across the blood-brain barrier. And they limit the production of neurotransmitter precursors, so that can lead to encephalopathy, cerebral edema, and death. The treatment is to withdraw protein, then reintroduce amino acids, keep the branched chain amino acid levels normal. Liver transplant is curative for these patients. Many of your patients may actually be on branched chain amino acid supplements. So patients will read about these on bodybuilding forums online, and they will take them in an effort to build more muscle, right? Their amino acids, they go into muscle. The data on that is actually a little bit debatable, but it's what people do. So this is a graphic showing that every year around New Year's, there's a spike in Google searches for New Year's resolution, branched chain amino acids, and workouts. So people are very interested in this, and they do think that it will promote health to take branched chain amino acids. What I'm offering here is actually a different story. We've known really since the 1960s that plasma branched chain amino acid levels are higher in patients both with obesity and with insulin resistance. In the left panel here, you'll see lean subjects, whether it's humans or rodents, in the blue, and those that are obese or insulin resistant in the yellow. Plasma branched chain amino acids are on the y-axis. So the lean patients in humans, in rats with genetic obesity, rats with diet-induced obesity, mice with genetic obesity, the lean subjects all have lower branched chain amino acids. In the panel on the right, there one of the branched chain amino acids, leucine levels, is in the y-axis, and an A1C level is on the x-axis. And as you'll see, as leucine rises, so does A1C. This meta-analysis looked at 18 studies with various metabolites, and they studied a lot more than just these branched chain amino acids. But they did find overall in the studies that branched chain amino acids increased the relative risk for type 2 diabetes, about 1.36%. Previously, we thought that increased branched chain amino acids were a result of insulin resistance. There's more recent data that suggests that an increase in branched chain amino acids actually contributes to insulin resistance. So for instance, in the Framingham data, they noticed that plasma branched chain amino acids were detected 10 years before even developing type 2 diabetes. When rodents were given BCAAs and a high-fat diet, their insulin resistance worsened. This is another theory for how increased plasma branched chain amino acids can lead to insulin resistance. So we start off again with nutrient excess. This nutrient excess can lead to increased plasma branched chain amino acid levels, increased insulin levels. It starts a certain signaling cascade that interferes with insulin signaling. The resultant insulin resistance increases the demand on insulin to dispose of excess glucose. Insulin resistance itself might actually increase the rate of appearance of branched chain amino acids from protein degradation already in the body. Then long-term demand for insulin secretion, as well as other things like lipotoxicity, can negatively impact the function of the islet cells, the beta cells, ultimately reducing the ability of the beta cells to produce insulin. Another theory posited is that increased plasma branched chain amino acid levels overwhelm oxidation in the adipose tissue and in the liver, and it's then shunted into skeletal muscle, which leads to lipotoxicity and insulin resistance. Branched chain amino acids are common in our food. We have high sources in beef, pork, fish, eggs, dairy, milk, nuts, seeds, beans, and lower concentrations in fruit and vegetables. So with Dudley Laming's data that low protein diet in humans improves glucose tolerance, decreases weight and fat. Also in rodents, that not only decreasing all amino acids, but just decreasing the branched chain amino acids will also lead to the same positive results. He posited, let's try this in humans. So this is our randomized clinical trial, the SOAR study, which we've been working on for the past several years. Thank you to the Department of Medicine R&D Committee for pilot funding for this. We've placed men on either a control protein diet, normal amounts of protein, or a low branched chain amino acid, men between the ages of 35 and 65, overweight, obese, BMI with pre-diabetes. And we give them a meal replacement powder for 60 days to replace 2 meals a day. The control powder is a whey protein powder that's commercially available that you can buy from the store. The low branch chain amino acid powder is a medical food that's used to treat maple syrup urine disease. They have a baseline food log that they fill out, and the registered dietitian counts everything up meticulously in that food log and makes sure that when they're placed on this intervention diet, that it's isocaloric compared to their baseline food log. So 2 meals are replaced with protein shakes. The protein shakes are usually mixed with fruit juices because low branched chain amino acid contents in fruit juices. And they do it for about 60 days. Our primary outcome is to reduce branched chain amino acid intake by over 50%. And we'll do this by food logs. So they complete 2 food logs during the time on the diet. Additionally, we can also check branched chain amino acids on blood samples. We really want to assess tolerability and palatability of this diet, and secondarily look at metabolic health outcomes. So we have 5 study visits total. The eligibility visit is where the subjects do the taste test to make sure that it's palatable for them. I've only had 1 subject come in for that eligibility visit who I said, absolutely not. I don't want to do this. I don't like it. And I've had 1 subject thus far who started on the diet for a week, dropped out after a week because he really didn't like the taste of it. Other than that, we've had adherence. So they're eligible. They come in for a baseline visit where we do measurements, BMI, waist circumference, an oral glucose tolerance test, an A1C. We measure their resting energy intake, DEXA scan for fat composition, jumping test for muscle function, and a baseline stool collection for microbiome. They start on the diet. 30 days later, they come in, give us their food log, go through counseling with the dietitian, more measurements, glucose, insulin, and a survey to assess how they've been doing, how much they like the meal replacement beverages. Day 60 of the diet, they come in and do that baseline testing 1 more time to see how things have changed over time, and another survey about their experiences with the meal replacement beverage. Throughout the study, we do weekly adverse assessment checks, safety labs, dietary counseling. After the diet is done, a couple weeks afterward, we bring them in again for another safety visit. Resting metabolic rate. Our basal energy expenditure is just the calories that we need to keep things going without the additional factors of what we're eating, physical activity, illness, stress from illness, and other things. Total energy expenditure is that basal needs plus diet-induced thermogenesis plus what we're needing for our energy during that day. This is one of the types of the machines that are used to measure resting metabolic rate. This is what we use to find out both what their basal energy needs are, and there's a calculation where you can figure out what their total energy needs are too. But what it uses are gas analyzers that measure oxygen consumption and carbon dioxide production to find out how many calories you need through indirect calorimetry. The DEXA scan that we use is the same scan that we all know from osteoporosis screening. It can also quantify fat. It'll give us a percentage amount and a gram amount for fat. Jumping mechanography, we have the subjects jump on a platform that measures force. This is to assess muscle function, which is important in a diet that's impacting protein. Thus far, we've had, other than this is not including the data from the subject who dropped out, we've had great adherence in both groups, over 95% for both the low branch chain amino acid group. We've had 6 go through, and the control group, we've had 5 subjects go through for that. As far as how much do you like the beverage, the low branch chain amino acid group liked it maybe a little bit less than the control group, somewhere between somewhat like and somewhat dislike, but they didn't hate it and they drank it almost all of the time. How filling are the beverages? Actually quite filling for the low branch chain amino acid group. And how willing are you to drink it? Definitely willing in our subjects. Adverse events, we've had some loose stools, nausea, headache, fatigue, nothing that was too major, and nothing that made anybody drop out of the study. So we need a couple of more participants yet. If you or anybody that you know is interested and would qualify for this, we're looking for males between the ages of 35, 65 with a BMI between 28 and 35, already diagnosed with prediabetes, willing to replace a couple of beverages with protein shakes for 8 weeks, not on any medication for diabetes or weight loss, not planning on starting any intense exercise routine like training for a triathlon or something like that. Subjects are compensated for their participation. There are 5 study visits in total. They happen in the clinical research unit here on D66. The first eligibility visit is consenting, describing the study, doing some blood draws, measurements, and the taste test takes about 2.5 hours. Those longer visits that I discussed with the oral glucose tolerance test and resting metabolic rate measurements are longer visits. They tend to run around 6 or 7 hours. There's only 2 of them that are that long. The halfway visit is pretty short. It's under an hour, and the final follow-up safety visit is also short. It's under an hour. So there is a little bit of a time commitment. But if you know anybody who would be interested, please send them my way. And this will bring us into our next study, which is really going to be the expansion, adding a whole lot more to the SOAR study. This will be SOAR 2. We're including all genders in this one. It'll be much larger, 132 people, not just a control diet and a low branch chain amino acid, but we'll also have a low protein arm as well. We're looking at fasting blood glucose and weight. We're also going to collect blood, adipose, tissue biopsies, and fecal samples for metabolomic and transcriptional profiling, trying to find key metabolic pathways, microbiota alterations that could mediate the impact of low branch chain amino acid and low protein diets on metabolic health. Take-home points for you. Remember, prediabetes, type 2 diabetes is on a continuum. It's the same pathophysiology. So if patients come in with a A1C of 5.7% and they're very concerned about it, we do know that it does actually increase risk for complications in the future, and we push the diet and the lifestyle very hard. 2 things: insulin resistance, relative insulin deficiency, and maybe we should focus on more than just carbs and fat for type 2 diabetes and prediabetes. Perhaps protein should be a huge component of what we do as well. I'd like to acknowledge so many people for this: Department of Medicine R&D Committee for pilot funding, such a great help for this. I'd like to thank Molly Carnes and the VA Advanced Fellowship in Women's Health for allowing me the time to work on it. Don Davis and Dudley Lamming are the PIs of the SOAR study, who have been most excellent mentors for me. The clinical research unit nurses and the administration, top-notch team. I do want to make a plug for the CRU. They can help with both inpatient and outpatient research if you need nursing for any reason, timed blood draws, infusions. Just give the CRU a call. They'd be able to help you with what you need for your project. ICTR, of course, Rachel Fensky, Lisa Davis in the CRU as registered dietitians, everybody in the Osteoporosis Research Center, Neil Binkley, Diane Krieger, Greta Borchardt, and Brittany Galusha and Unhei Park, who put a lot of work into this study as well. And that's what I have. I can open it up for questions.
Great. Well, thank you so much, Dr. Karaman. It was a wonderful overview and a little PTSD for me going back to, the TCA cycle.
For a lot of us, yeah, I hear
that. Please put your questions in the Q&A. And just a reminder, I am expecting some questions from our medicine residents. And in the meantime, so as you were describing the low branched amino acid diet, and thinking of, would this be a sustainable outcome or approach for the general population? I'm thinking, at least personally, no. So how do you see, if this does come to fruition and does seem to have an impact, how do you incorporate it into a lifestyle? How do you make those incorporated for a long generalizability and sustainability?
Right. So as far as what we've seen from our subjects, they're able to do it for 60 days without a problem. Some of them said, I could do this longer. There will always be a segment of the population that is not able to do liquids for meals, and that's okay. They don't necessarily have to. Those patients, once we expand the study and find positive results, those patients can be counseled by a dietitian on how to decrease branched chain amino acid diets in solid food outside of protein shakes. So the USDA has quantified all of the amino acids in every single food that you can imagine. So we have lists of what's high and what's low in branched chain amino acids. And working with a registered dietitian, patients can meal plan that way for the people that don't want to do shakes. If we receive the positive results that we think we will, perhaps it could also be marketed in terms of low branched chain amino acid shakes outside of treatment for maple syrup urine disease. So I think there will always be part of the population who's willing and able to do this, particularly the people who feel like they've tried everything thus far, everything that's commercially available, and want to do something that's a little bit different. And for our research right now, we found that adherence has really not been an issue for those 60 days. Well, it remains to be seen what the metabolic outcomes will be and how quickly that will happen as well. And it could depend on how much weight needs to be lost and also the genetic makeup of the subjects as well. But I think that there's a good chance that this will work, particularly because decreasing the low protein diet in that previous randomized controlled trial that I showed you, they were on it for 43 days and lost 2.6 kilograms in those 43 days, which is relatively significant.
Yeah, great, thank you. A question from Dr. Juckett. We hear much about inflammatory aging as we get older. Do we know anything about decreased branched chain amino acid intake and the correlation with inflammatory markers with aging? If you have a decreased branched chain amino acid diet, do you see decreased markers of inflammation?
That would make a lot of sense. That I have not looked into yet. I can look into that and get back to you, but it would make a lot of sense.
Yeah. And a bit of a follow-up from Michelle Kimball. What kind of metabolomics analysis are you going to be doing in SOAR2? Are you doing pre and post? And are you going to be able to do a correlation between your signature from the metabolomic study and failure and success of your outcomes?
That would be a deal. That would be, yeah, that would be terrific.
Great. From Dr. Cheda, you had mentioned that many of the standards were based on ethnicity, that the cutoffs, and there's been a lot of discussion about whether this is appropriate or not. What are your thoughts, particularly for endocrinology, for the waist circumference measurements, for example?
So in my practice, I do find it valuable. And this really depends on kind of your philosophy and the way that you have looked at the data. But I think that the data is pretty valid that for certain ethnic backgrounds, we see the type 2 diabetes pathophysiology at lower BMIs, lower waist circumference, and that would make us really more cautious for people who come in and maybe aren't classically overweight with a BMI of 25 or higher. So for me, I do use it in my clinical practice. It's not for everybody, though.
Okay. And from Betsy Trowbridge. So your patient says, I'm taking these high protein shakes. What do you say to them? You encourage them, discourage them?
So yeah, based on our data, I would say, I leave it to every patient to kind of live life how they want. I'm here for counseling. So I would say, I have data that shows that perhaps removing these branched chain amino acids would be more beneficial for both glucose tolerance and weight. And maybe it's something to think about, particularly for these patients who are going on the bodybuilding forums, online, social media, where it's pushed heavily as an answer and perhaps they're not showing the other side of the story. So it's good to provide additional information.
Okay, great. Other questions? Okay. Great. I think we are done. I want to thank you again for a wonderful overview of diabetes and bringing up a number of intriguing questions. Because there's a question in the, from Dr. Crines. So Dr. Crines, one final question. We'll let Vince have the final say. Can you just wait? Why don't you ask it? Go for it.
I'll ask her the old-fashioned way, or like perhaps the new-fashioned way. So I was curious about whether just avoiding, if you gave a person a list of foods that were high in branched chain amino acids, what kind of reduction could you expect someone who was pretty diligent with that as a way of maybe bypassing the need for the, the shakes that are missing those amino acids?
Yeah, I think it would be possible with a very involved dietary counseling, and it really depends on what the patient likes to eat, right? If there's somebody who says, oh yeah, I'm not giving up beef, pork, nuts, I'm not giving up any of that, it's probably not going to work that well. But if they're willing to work with it, focus on the fruit and vegetables, and perhaps find alternative sources for proteins that they hadn't been using before, if they're open to it, the feasibility of that would work. So
not really good for carnivores.
Difficult. Difficult. Yep.
All right. Well, with that, thank you so much for a wonderful overview, and I hope everyone has a great weekend, and we'll see you next week. Take care. Bye-bye.
Bye.